Let's talk about why you should deprescribe proton pump inhibitors, how to manage patients' expectations and concerns, non-pharmaceutical alternatives to treat acid reflux disease, and appropriate tapering protocols. First, why you'd want to deprescribe PPIs. Often the hardest part of stopping a PPI is identifying why the PPI was prescribed in the first place. Sure, there are several valid reasons to use PPIs long-term, including Barrett's esophagitis, severe erosive esophagitis, chronic use of certain medications, and history of a major GI bleed, but up to 80% of patients worldwide have no valid indication for their PPI. And the evidence-based deprescribing guideline and algorithm recommends deprescribing PPIs for patients without a valid or known indication. Also, for most indications, clinical guidelines recommend treating with PPIs for a maximum of 12 weeks. The Canadian Association of Gastroenterology recommends deprescribing long-term PPIs at least once per year. You might ask why. After all, PPIs do have benefits. They work quickly and effectively to resolve gastrointestinal symptoms. On the other end of the scale, the harms from PPIs accumulate over time. So when there's no indication and you use them long-term, the scales get tipped towards harm. Now let's talk about managing patients' expectations and concerns. I consider myself a bit of a deprescribing superhero. And here's what I've learned. When you deprescribe PPIs after long-term use, a repeat scope is not required. Did you know 91% of patients become symptom-free on continuous PPI treatment, and 84% continue to be symptom-free when PPIs are deprescribed to PRN? Although some patients may experience rebound symptoms, they only last a few weeks and are easily managed. It's important to let patients know that they may develop withdrawal symptoms in the first few weeks after deprescribing, but that this is not a return to the original condition. Episodic use of PPIs, H2 antagonists, or antacids, when required, are all equally effective options for managing withdrawal symptoms. Increase patient buy-in by engaging them in the best approach for managing potential symptom return. Another way to get great results from deprescribing PPIs is to reinforce non-pharmaceutical alternatives for acid reflux disease. Use our Empower brochure to educate your patients about lifestyle changes, such as avoiding trigger foods, quitting smoking, and losing weight. If your patients still aren't sure about deprescribing, propose a trial. Remind them that if their symptoms return, you can always restart if necessary. Finally, discuss appropriate tapering protocols with your patients. Options include using a PRN PPI, H2 antagonist or antacid, tapering dose reduction, cutting the dose in half for a week, or taking on alternate days. Walk your patient through the tapering example in our Empower brochure. Now you've saved money, reduced polypharmacy, practiced evidence-based medicine, and cut the risk of long-term adverse events. If your patient is on PPI, and if there's no valid indication for long-term treatment, become an evidence-based deprescriber today. What are you waiting for?